and welcome to today's Psoriasis and Mental Health Connection webinar. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, dermatologist and psychiatrist, Dr. Evan Rieder. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, Bristol Myers Squibb, Janssen Pharmaceutical Companies of Johnson & Johnson, Lilly, and Novartis for their support of today's webinar. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan in July 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over the next 5 years, NPF will focus on achieving 3 goals to lead collaborative, transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research includes, to date, NPF has funded over $24 million in grants and fellowships. This includes over $3 million in grant and fellowship funding announced this past summer. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grant and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant, which are new to the Foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged a definition of prevention to better guide proposal development. And that's how it expanded to disease relapse and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. Second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the U.S. The registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 11,915 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. Not sure if they are? Just ask. And if they're not, encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or good-tape psoriasis, and be a candidate for office or home phototherapy. There is no washout of topical, oral, or biologic medications, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you are a patient, answer survey questions, which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The NPF annual survey is a data collection effort the Foundation has conducted for 2 decades. This important research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we would appreciate you sharing your experiences with us. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis, walk, or cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about how biological mechanisms increase the risk of depression and anxiety amongst those with psoriasis and psoriatic arthritis, prevalence of depression, anxiety, psychosocial stress, bipolar disorder, and other associated mental health issues among people with psoriatic disease, the role of mental health in managing psoriatic disease, and what you can do to improve overall health, resources to continue to learn more about the mental health connection and how to cope with psoriatic disease. Now I'd like to introduce you to our speaker, dermatologist and psychiatrist Dr. Evan Rieder. Dr. Rieder is an assistant professor of dermatology at Ronald O. Perelman Department of Dermatology at NYU Grossman School of Medicine at NYU Langone Health. Dr. Rieder treats a wide variety of skin and nail diseases, which include psoriasis, hyperpigmentation, skin tumors, and more. He is a member of the American Academy of Dermatology, the American Society for Dermatologic Surgery, the Council for Nail Disorders, and the American Psychiatric Association. Dr. Rieder also hosts the dermatology show on Sirius XM's Dr. Radio, where he discusses a variety of dermatologic issues. Dr. Rieder is one of a few physicians in the U.S. who is board certified in psychiatry and dermatology, which offers a unique perspective on the management and quality of life associated with skin diseases such as psoriasis. Such unique insight also makes him the perfect speaker to address the connection between psoriasis and mental health issues. It's my honor to welcome Dr. Evan Rieder.
Okay, thanks, Bev. Here's my following disclosures, none of which are relevant to the talk today, except for one, which being Happify Health. I do some consulting for them, and they run a program for psoriasis called COPA, which is a community, an online community for people living with psoriasis, but the rest are not relevant to what we're going to be speaking about today. But I do want to thank Bev, and I want to thank the National Psoriasis Foundation for having me here today to talk about a topic that I think is really, really important to me. You know, one of the first conditions that I was ever interested in when I was a medical student, thinking about the world of dermatology and thinking about the world of psychiatry. So it's really an honor for me to be here. And I also want to thank one of my dermatology mentors, Dr. Rick Fried, who is a psychologist and dermatologist who actually made the connection for me with the National Psoriasis Foundation. I doubt that he's here tonight, but I wanted to give him a shout out as well. Okay, so here's the outline. It looks very brief, but we're going to spend a little bit more time on each slide than typically is done by dermatologists who tend to whip through the slides and have a lot of data on them. So I'm going to talk about why I think psoriasis is a unique condition. All skin conditions are unique in their different ways, but psoriasis is particularly unique in terms of what we've been learning about in the last 10, 20 years. We're going to talk about the evidence, the mechanisms of action that sort of link psoriasis to mental health comorbidities and quality of life, and the clinical data, what we actually see in people's lives and what we actually see in the clinical trials. I'll give some of my management tips, my sort of specialty tips that I like to teach to other dermatologists, helping people deal with quality of life issues and psychological issues that happen in their patient populations, and we'll sort of wrap things up from there. I specifically made this talk with the idea that we would have time for questions, so hopefully we'll be able to answer all your questions. And I know some already started floating in and they're really great, so I look forward to having some healthy discussions afterwards. All right, so psoriasis is different, right? This is what I was always told when I was a medical student, but we know psoriasis is different because the physical and mental impairment can be very, very severe, and they can be on par with conditions that people in the world of medicine don't think think that are much more severe and much more burdensome to people's quality of life and people's health than psoriasis or any other skin condition is. But we know that psoriasis is different because the mental health and physical impairment can be on par with things like cancer and arthritis, hypertension, heart disease, diabetes, and depression. And even beyond the health ramifications, psoriasis is associated with decreased employment and work productivity. So the effects are beyond just what's happening in the doctor's office and really extend to people's quality of life and their social and occupational functioning. So the question that was sort of presented to me when I was a medical student in 2007, 2006, when I was sort of interested in this was, is psoriasis different because of people's internal experience living with the condition, or is it a reactive state that they're going into because of the response that they're getting from other people? So one of the things that people told me when I was initially interested in psoriasis as a medical student is, oh, psoriasis patients are very different. And I said, what does that really mean? I thought that was sort of an interesting topic, but people would give me the anecdote that some dermatologists would say, you know, I have patients with psoriasis, they're covered head to toe with scaly, red lesions that are very itchy, and this really ruins their quality of life. I said, okay, that sort of makes sense to me. And then they also said, well, I also have patients that may have a coin-sized lesion on the back of their elbow that really isn't in a place where anyone can see it. And they also have extreme levels of worry and their extreme levels of depression. And the sort of what was told to me at that time was that psoriasis, people living with psoriasis are just different and they have a different response. So that made me think there must be something else going on here. So I think that what really started off as a sort of benign curiosity and speculation was really founded on ignorance and some misinformation. And sort of over the last 10 or 20 years, we've really gotten a better idea of the connection between psoriasis as a skin condition and what's going on in our internal state, not only in what's going on with the cardiovascular system and the lungs and the liver, but what's going on in the brain as well and the endocrine system. So I do want to mention what I call the role of the observer. So we sort of know the stories, and I'm sure a lot of you have lived the stories, being criticized at the pool by taking your shirt off and trying to get in the water, and people are scared of being infected by your skin, which has psoriatic lesions on it, which we all know are not infective, but basically based on ignorance and misinformation again, or having judgment during intimacy, romantic partners, social interactions. And this is sort of just leads to this propagation of poor self-esteem, social anxiety, and even changes in our personality structure that can be long lasting. So I wanted to dig a little bit deeper into the data to look beyond the stigma and the psychosocial factors and sort of talk to you about like what the evidence is showing from a scientific perspective. We know that psoriasis is a chronic inflammatory skin condition with a lot of medical comorbidities, like I've already alluded to, with liver and respiratory disease, with psoriatic arthritis, with cardiovascular disease, with metabolic syndrome, the sort of global inflammatory disease that people get with dysregulation in their blood sugar and their blood pressure and their weight. But how does psychiatric disease fit into the picture? So the hard science data can be a little bit difficult to follow, so I'm going to try to break it down to make it a little bit easier. But I think if you're going to be thinking about the biological mechanisms of psoriasis and mental health comorbidities, you have to think about the inflammatory theories of depression and making that link between psoriasis and mental health comorbidity. Now, there's a lot of different ways that people can get depressed. I think about the word of depression as sort of a wastebasket term. There's lots of ways that people can get there. There can be something going on in their life that's an external factor that's happening socially. There can be something that's happening in the workplace. There could be that causes people to be depressed, or they could have something just happening organically in their brain that their life seems perfectly rosy from the outside, but there could be something happening to their brain that's sort of geared from the inside of their body that's making things inflamed and leading them to have depressive symptoms, low mood, poor sleep, difficulty enjoying things, sometimes thoughts about death, sometimes thoughts about wanting to hurt themselves. And this is a feeling to anyone who's been depressed. They may have had some or all of these symptoms in the past. But when you think about depression and neuroinflammation, and we really think about, this is one of the potential reasons that people get depressed is sort of an inflammatory depression. There's really a complex interaction between the endocrine systems, which is the hormones, the immune system, which should be doing good things like fighting infections, and the monoamine neurotransmitters. And there's a big dysregulation that's happening between these systems. The monoamine neurotransmitters are probably better known to you by their common names, which are serotonin, norepinephrine, and dopamine. These are most of the molecules that are acted upon by a lot of the psychiatric medications, particularly the antidepressants like Prozac and Paxil and Wellbutrin, that may be familiar to some of you. And if you work in the healthcare professions, they're definitely familiar to you. But like I said, there's many different ways to arrive at a major depressive episode. But I want to talk about depression and neuroinflammation as a potential mechanistic link between psoriasis and mental health comorbidities. We're probably not going to have enough time to talk about anxiety today, but we're going to talk a lot about depression. So the way that we think about depression right now is that with this dysregulation between multiple systems in the body, you need to have an inciting event. And that we think about that as an environmental stress. And that's really the basic way we think about most psychiatric phenomena these days, even if we can't really understand the basic pathogenesis of our psychiatric diseases. And really that's the way that things are with our most common psychiatric diseases, depression, and to a lesser extent, maybe schizophrenia. We have a good idea about how our substance use disorders function and how our anxiety disorders happen, but depression, we're still trying to wrap our minds around it. But we think about an environmental stress triggering this cascade of bodily functions that are happening like inside our bodies. And then this cycle gradually becomes self-sustaining, and then a depressive episode is allowed to perpetuate and may go into remission. And then an environmental stress, and it doesn't matter what that kind of stress is. It could be a medical illness, it could be a relationship breakup, it could be a financial stress, it could be even a new medication that sends your body haywire. All these different things can be environmental stresses that can trigger a major depressive episode. So this is I think a busy slide. It's sort of a cool graphic, I thought, but it's sort of difficult to follow. So I want to give you the take-home points, and then I'll just sort of walk you through it with a little bit more clarity. The take-home points are that stress on the upper right is interacting with the brain, and it's interacting with the inflammatory markers that you can see sort of in those little dots down here below the stressful incident, and inflammatory cells down here, and the adrenal gland, which is a hormonal gland that sort of makes steroids that get released across the body. So the take-home points is stress can interact with all those different things, causing a big dysregulation of how the endocrine system functions, interacts with the brain, and how that interacts with these inflammatory markers that all get sort of upregulated and sort of put into dysregulation during the stressful episode. So basically what's happening is you have a chronic stress that's activating our endocrine system, something called the HPA axis, which you can see down there in figure 1. And again, it's not important that you remember all the details of this, but just to give you a big overview. So when you have dysregulation in the way that your endocrine system is functioning, that can feed back on the brain and a little part of the brain called the amygdala, which is really important for fear and emotional processing and stress learning. That can also increase the release of some pro-inflammatory markers that you see there on the right, and the lettering that's probably too small to see: IL-1, IL-6, CRP, TNF-alpha, interferon alpha. And those cytokines are those little molecules that get increased, and those steroids that get increased from the adrenal gland cause increases in something called monoamine oxidase. So monoamine oxidase is an enzyme that breaks down those monoamines that we talked about on the last slide: your serotonin, your dopamine, your norepinephrine. And when those things get broken down, that's when that's what we think about as a really basic reason that people may get depressed. Obviously, it's much more complicated than that. It can also feed back on the brain and decrease the way that new nerves are generated, and decrease the volumes in different areas of the brain, like the hippocampus, which is part of this little inner circular area here, sort of down here in the bottom, which is important for memories and learning and emotion. And with that, all these things being dysregulated, you can get increased levels of physical illness, increased risk of inflammatory disorders, including cardiovascular disease. And that's like a really high level overview of the interaction between stress and how it can initiate this big cascade of events in the body where there's a big inflammatory outburst and there's major dysregulation between the brain, the neurons in the brain, these inflammatory markers, and the endocrine system. But we know that psoriasis can be triggered by stress, and stress can also contribute to psoriasis flares. And we know when we look into the data, the high daily stressors and low cortisol levels characterize psoriasis flares because there's a feedback loop that happens and cortisol levels get depressed. And because of that, people with psoriasis may be vulnerable to the influence of stressors on psoriatic disease. We even have some neuroimaging to back this up. I don't have the images here because I didn't think that they were going to translate very well over the webinar, but we have a couple different types of brain imaging studies, one that's called positron emission tomography, and one that's called magnetic resonance imagery. And those are very high sensitivity ways of imaging the brain, and they can show a couple things during depression. One, you can see increased levels of monoamine oxidase, that enzyme that breaks down all those neurotransmitters that we think about as so important. So with those decreased levels of neurotransmitters, 5-HT is serotonin, that's just an abbreviation for it. You get decreased levels of serotonin, and sort of colloquially, we think about serotonin as being sort of like a happy neurotransmitter, things that make people feel good. When those levels go down, the receptors for the serotonin go up, okay? And when they go up, we know from the data, when people have high levels of serotonin receptors that are sort of unoccupied, that can be associated with suicidal ideation, which is obviously a symptom of depression as well. And when you look at the MRI studies in people who are depressed, we can have people with an overly active area called that amygdala, which I sort of talked about on the slide before in the brain. But it's really important to know that amygdala is really important thinking about emotional reactions, especially those that are connected to fear or the fight or flight response. And that is overly active in response to sad stimuli, but kind of quiet in people who are shown something positive. So all these things get dysregulated in people with depression. So you're thinking, how is this related to psoriasis? Well, I'm going to tell you in a slide here. So, and we also know that there's inflammation and depression. Inflammatory conditions can be associated with an increased prevalence of depression. And we know in major depressive disorder, like we were talking about in the last slide, there is an increased number of pro-inflammatory cytokines. So those cytokines that we were talking about in that little graph before, IL-1, IL-6, TNF-alpha, and CRP. It's not important that you remember those names, but what is important is to know that these same cytokines are upregulated in people who have psoriasis, another type of inflammatory condition. So that is sort of hinting at, alluding at a possible and potential link between inflammatory theories of depression and psoriasis. There's a lot of data that's looking at something called the anterior cingulate cortex, which is highlighted here in red, which sort of interacts with the behavioral and emotional response system in the brain, this system of interlinking areas of the brain, this circuitry called the limbic system. So that'll be the most technical we get with this talk. But what's the clinical data show? The vast majority of the clinical data comes in actually the most of it comes from the quality of life studies in psoriasis. So we're actually not going to talk about that so much because I feel like it's really been hammered home, and we know that psoriasis has been associated with decreases in quality of life universally. It's been repeatedly shown, and that's been happening for years and years and years. But we're going to talk about psoriasis association with depression and what's shown clinically in our clinical trials and what we see in clinical practice, suicide, and maybe a couple other topics we'll touch on as well. When you look at depression and psoriasis, it really depends on the scale that's used in the patient population. This is a huge range, okay? So MDD, or major depressive disorder, has been noted in between 9 and 55% of people with psoriasis. It's a big range. Again, it depends on the scales that are used, but the association is there and it's been repeatedly shown. But the role is nuanced. We don't know if it's a trigger, an exacerbating factor of psoriasis, or comes as a consequence of people living with psoriasis and having issues with self-esteem because of the way that they feel and the way that they feel their skin looks, or the uncomfortability of having the lesions on their body, or the role of the other, the observer, who's sort of passing judgment on them silently or even out in the open. So again, the role can be nuanced and can be multifactorial. And like I said before, there is a known association with decreased quality of life, so much so that I don't think it bears worth talking about it for a substantial period of time, because it's so established now that we know that we have to be asking people with psoriasis. And as a person who's living with psoriasis, you have to know that this can be a concomitant thing that you have to live with, dealing with psoriatic disease for a various number of reasons. But we know that when we look at these studies, there's a couple of different questionnaires that are given to people in psoriasis studies. One is called the Dermatology Life Quality Index, and one is called the Patient Health Questionnaire number 9. So the first one really looks at quality of life, and the second one looks at depression. And we know that there has been discordance found between those two studies, and the DLQI, which is used in most of the psoriasis trials, has not been so accurate, and it misses some people with depression. So in the old studies when we were looking at dermatology quality of life, we may have underestimated the prevalence of depression in some of those studies. So it's sort of something that's worth noting. Now, stress and psoriasis, I sort of talked about that a little bit on a previous slide, but the association of psoriasis with anxiety and stress is also well established, just like decreased quality of life. But the true biologic data, like the hard science data connecting them to, is sort of limited. We have the qualitative evidence talking about people's experience and questionnaire studies, but there was one interesting study that I found that gave initial data for dysfunction in this neuroendocrine system that I alluded to before, the HPA axis. So there was a study that came from Brazil. It's not a huge study, but it was intriguing in that they gave people two different questionnaires, the DLQI and the PHQ-9, looking at quality of life and looking at depression, and they used the PASI. If any of you have ever been in clinical trials as a patient, or if you worked in clinical trials, you may know that the PASI, the Psoriasis Area Severity Index, is the way that we sort of scale psoriasis in our clinical trials. And they assessed all the subjects using those three things, and as well as using sort of a narrative of life events that were stressful. They assessed these stressful life events in 119 psoriasis patients with 3+ years of at least moderate to severe psoriasis. And what they found was very interesting, because they were taking salivary cortisol samples throughout the day. They would do it 3 times in the morning when cortisol is supposed to be at highest. They would do it in the afternoon, and they also did it at bedtime. And they found a significant association between bedtime salivary cortisol and the PASI, meaning that the higher cortisol scores were associated with the increased severity of psoriasis, which is really one of the only studies that I found that to show the true biologic connection between stress in the body, actually measured in an objective way, and psoriasis. Now, suicide and psoriasis, I thought I would touch on that as well, because it's sort of a hot topic, and that's one that's debated a lot in the psoriasis literature. And that's one that I think there's a lot of controversy from dermatologists, because if any of you are familiar with the data that came out from a drug that's really not widely used anymore called brodalumab, there were a couple suicides in people who were taking this biologic medication. It's an amazing biologic medication. So it's sort of a hot topic, and it's sort of a controversial one, because study data were a few people that, but much more than would be expected, had suicide attempts. But when you look at the data for psoriasis and suicide, unlike depression, it has not been consistently associated. It seems that people who are younger living with psoriasis and people who have more severe psoriasis have an increased risk of suicidality, and there's increased psoriasis-related stressors, and decreased quality of life can be associated with suicidality as well. But like I said before, not consistently observed, unlike the establishment with depression. Some other areas of interest that consistently show up in the psoriasis data in terms of the comorbidities with mental health are a concept called alexithymia, which may not be familiar to you if you're in the United States, because most of this data comes from Europe, and it's not a topic that we tend to talk about very much in the world of psychiatry in the United States. Sleep dysregulation and the association between psoriasis, depression, and cardiovascular events. So alexithymia is a difficulty in recognizing and describing emotions, and that's been shown in about a quarter of psoriasis patients, predominantly coming from the European data. I'm not sure, from my perspective, what to make of that. And I haven't seen much in terms of what that means and what that means for people living with psoriasis, or how they can be helped. But it seems like some people have difficulty articulating their feelings. And while they are maybe having decreases in quality of life or depression, they have trouble finding the words for that. Sleep dysregulation is also another hot topic of psoriasis and mental health comorbidities. And we know sleep is necessary for immune function and metabolic function, our cognitive processes, our emotional regulation, and it's been associated with all sorts of internal systemic processes like diabetes, high blood pressure, cardiovascular disease, and it's been associated with an increased risk for depression and anxiety. So sleep is a really, really important phenomenon, not only for mental health comorbidities, but for our sort of systemic functioning at large. And then because psoriasis is such a multi-system disorder, there's a complex interaction between psoriasis and all these comorbidities. And psoriasis, and when associated with depression, may trigger a metabolic syndrome, may also aggravate underlying conditions as well. And I was asked to talk a little bit about bipolar disorder. So the good news is there's not that much out there, but the bad news is that the consensus on bipolar disorder is still lacking, and we don't have that much data right now. There was an interesting paper that came out recently in one of the psychiatry journals saying comorbid psoriasis bipolar disorder was successfully treated with apremilast. Some of you may be familiar with this medication, or Otezla. So, and they were positing there could be sort of mechanisms of action that could be shared between bipolar disorder and psoriasis. But when you look at the data, it hasn't been consistently associated, and some of the data has shown that bipolar disorder was not seen in greater numbers in people who had psoriasis, looking at massive databases where people were able to show an association between psoriasis and anxiety and psoriasis and depression. But there are hypothetical mechanisms that may be shared between bipolar disorder and psoriasis. They may be genetic, and there's some speculation that immune dysregulation plays a role in bipolar disorder, but we're really sort of not really sure about that right now. And I think that one of the most important things to think about with bipolar disorder and psoriasis is the role of confounding variables. So something that's getting in the way that may be skewing the data is the role of medications. A lot of the medications, or almost all of the medications that are consistently used to treat and keep people who are living with bipolar disorder sort of mood normal and euthymic, are medications like lithium, Depakote, and some of the second generation antipsychotic medications. All these medications have been associated with flares of psoriasis. That's one of the oldest things that we learned, is the association between lithium and the exacerbation of psoriasis. So it's really hard to tease out that data. However, this paper that I sort of copied on the bottom did talk about a potential mechanism of action, and that's through altered phosphodiesterase 4 expression and something called cyclic AMP activation. So those are mechanisms of action that we know are sort of necessary for the pathogenesis of bipolar disorder and psoriasis alike. And if you inhibit those with a medication like apremilast, that may inhibit both bipolar disorder and psoriasis by blocking phosphodiesterase 4 and blocking this downstream effects on this molecule called cyclic AMP. So in this patient they were talking about in particular, they had sort of an interesting phenomenon where they had increased severity of psoriasis lesions that were associated with manic episodes in sort of a cyclical way that seemed to be very predictable. This is a case report, this is not a controlled study, and it was a single patient, but it sort of alludes to the potential connection between psoriasis and bipolar disorder, but I think that connection is not particularly strong at this time. So what, right? So we have these potential links between mental health comorbidities and psoriasis, and I've seen a ton of talks about these topics, and we see a ton of these topics written in the dermatology literature, but I don't see a lot of people talking about what can be done about this. And I really think that there's few programs that have been designed to address this. And I think that the goals of these programs should be to minimize stress, because we know that what chronic stress can do, from that little cartoon I showed before, can dysregulate everything. And what can we do to maximize our well-being? And where does this lead? How do we respond to this? And how do we do so in the office? And how do we do so at home? I think a lot of this has to do with regulating sleep and doing repetitive, simple interventions that sort of they may sound like homework assignments to some of you, but they're interventions that I found to be helpful in some of my patients. So what do I recommend in office? I recommend advocacy in multiple ways, both from the dermatologist for their patients and for patients with their dermatologist advocating for themselves. I always tell my patients, I work at NYU, but I'm a doctor, but I'm also a patient at NYU, and I'm actually surprised by how much you have to advocate for yourself as a patient. There's a lot of things that I would do for myself that don't always happen in a doctor's office because the doctors are busy, or because there's something they're not looking at, or because there's something that I don't understand but I need more explanation for. You must advocate for yourself as a patient with psoriasis. If you feel like you're not being adequately treated, dermatologists don't have the luxury of time, and they don't always ask the right questions. There's 2 questions that are found in something called the PHQ-2, which is the Patient Health Questionnaire 2, which is a shorter version of that PHQ-9. And that asks 2 questions that are very sensitive for depression, about your mood during the last 2 weeks, and if you're able to enjoy yourself over the last 2 weeks. Dermatologists should really be asking you those questions. If they're not, you can sort of let them know that I haven't been doing well, my skin may look clear, or my skin may look not as clear as I want it to be, and I want additional help with that. So dermatologists have a lot of reasons for not asking those questions, and I think a lot of it has to do with time, but I think it makes sense to be your own best advocate. I sort of help sort of advocate for patients on the point of dermatologists, trying to get them to ask these questions, trying to make sure that they're asking about depression and quality of life decreases, particularly in patients who are living with chronic inflammatory diseases like psoriasis, where we know it can be associated with mental health comorbidity. Multidisciplinary teams can be really helpful if you can go to a clinic that has a dermatologist paired with a psychologist and a rheumatologist. Those models do exist. We have a clinic at NYU that has a rheumatologist and psoriasis expert sort of teamed up together. I know one of my colleagues at Rochester has a very similar clinic like that. They exist, and there's going to be more and more of them with time. And mental health, another thing I try to do, people ask me all the time, how do I get my patients to see a mental health provider? Well, I think part of the thing is to sort of destigmatize what it means. I always share with people, I see a psychiatrist, I do that weekly, I've been doing it for a long time, and it can be a self-indulgent thing to do for an hour or 30 minutes or however long your session is. Someone is just talking to you and helping you sort through the issues that are bothering you. And it can be really, really transformative if you're committed to it. And I like to think about it as an adjuvant to the dermatologist-patient relationship. The dermatologist-patient relationship will continue even if you're seeing someone as a mental health provider that can help you sort of sort through some of the issues that you may be dealing with psoriasis or in other parts of your life. And I will say that talk therapy is online now, so it's much more accessible. I thought it was going to be weird, but it's not that weird. I do it myself on my phone, and it's great, and it's more widely accessible because of that. We usually think about something called cognitive behavioral therapy as like the bread and butter of dealing with depression and anxiety in the office setting, but there's a couple of different treatment modalities that have been used. Motivational interviewing is a treatment modality we use to try to sort of give patients autonomy, help them feel like they're patient-centered, they're making their decisions, and help them resolve ambivalence. It sort of helps elicit your motivation to change a specific negative behavior in your life. This is used very frequently in people who have substance use disorders, but it's been used in people with psoriasis as well, who may have difficulty sort of staying on board with a medication regimen, and sort of ask things like, how might you like your life to be different, or how does psoriasis interfere with the things you would like to do in your life? I'll probably skip over acceptance and commitment therapy, but it basically helps you accept the feelings that you have are appropriate. Maybe that's depression that's associated with living with psoriasis, sort of respond to them appropriately and don't let them prevent you from getting in the way of moving forward. So accepting your issues and committing to moving forward in a practical way. And I also want you to think about medications that may be prescribed by psychiatrists, but not necessarily so. That could be very helpful. And then biologic medications. I want you to think about those as antidepressant, because every single trial of psoriasis shows that these medications that are given by injection that are made for psoriasis are helpful for people in their quality of life and helpful for people in decreasing their symptoms of depression. Some more granular stuff that you can do at home, because I want to leave some time for questions here. Diet and exercise. It sounds silly, but diet and exercise improve psychological functioning. So a hypocaloric diet with weight loss is recommended by the medical board of the National Psoriasis Foundation, especially for people who have a body mass index over 25, but it improves the weight, it decreases metabolic syndrome, and it can improve mood. Mediterranean diet, there's not as much data for that. There's some questionnaire studies, but there's not a lot of hard data that shows that psoriasis severity is inversely related to adherence with a Mediterranean diet. So the more you adhere to a Mediterranean diet, the less severe your psoriasis may be. Again, it hasn't been shown widely, but it's a very heart-healthy diet, which is highly recommended. Vitamins have not been shown to have a meaningful impact on psoriasis severity or mental health quality of life. There's insufficient data on that right now. Gluten-free diet, similar. Gluten-free diet can be helpful if you have psoriasis and celiac disease. That's definitely recommended. For people who have like a gluten sensitivity or just kind of feel bad or bloated after eating gluten, it may be worth taking a 3-month trial off of gluten, but I can't make any promises to what that will do for your psoriasis. And then a ketogenic diet has been something that has been presented to me by people who are in the weight loss doctors practicing for years, and they said they have patients with psoriasis went on a ketogenic diet, lost a lot of weight, and their psoriasis got better. There was an interesting paper in one of our top dermatology journals that showed that ketogenic diet can actually make psoriasis worse. So right now, the jury's out on that one. We have people with 50 years of clinical experience saying it works, and we have one paper in mice saying that it doesn't. So take that for what it's worth. And then finally, exercise, okay? Exercise, we know, decreases incident psoriasis the Nurses' Health study has shown that, and a regular exercise decreases the risk of developing psoriasis. These are my last things that I like to tell people to do at home. These are easy to administer psychological tricks that are sort of evidence-based that can help with stress, anxiety, and mood. And like I said before, you want to treat them as like homework and practice them, even when you don't feel badly about yourself and you don't feel stressed out and you don't feel anxious, because if they're not practiced regularly, they won't become rote. I tell my patients when they come to see me, you should be practicing these things like their homework assignments, like breakfast, lunch, and dinner, doing them 3 times a day until they become rote. And so at that point, you'll be able to put them into play when you actually need to. And they sound really simple when you do them, but they're actually very effective. And you can find them all over YouTube. I'm making my own recordings. I have to put them up online, but I'll make them available for free. But something called deep abdominal breathing, which is familiar to you if you play any instruments like woodwind instruments or like brass instruments where you have to hold your breath for a long time. Progressive muscle relaxation, where you're sort of progressively going up from the muscles of your feet all the way up to your legs and your arms and your belly and your chest. Clenching your muscles and relaxing them will systematically relieve tension in your body. Paired with deep abdominal breathing, it's an amazing thing to decrease stress, to decrease anxiety, or even for insomnia. And then something called guided imagery, which sort of takes you on a guided experience in your mind's eye, where you sort of listen to someone's on a recording and imagine yourself in a beautiful place. It can be a very, very nice stress relieving activity to do, especially when done in the moment when you're feeling a lot of anxiety. And then communities. I talked about the one relative conflict of interest I had, or in the first slide with a company called Happify Health, and their product called COPA, which is a psoriasis community that just launched a couple of months ago. But there are other communities out there, and I think it helps to be connected with like-minded people and people who are living with the same condition, because there may be some alternative treatment that you want to try. You may want to know if someone's experienced using Cosentyx. You may want to just want people to sort of have like a more of like a group therapy online. Having community can be very supportive and can help keep you checking in with people on a regular basis, and can help your quality of life and help you feel supported. And then here's Insight Timer. It's just, I have no financial relationship with this, but this is an example of an application that you can download, and you can do like guided meditations for 5 minutes up to an hour and choose lots of different topics that I find this to be very helpful, and it's free. And so in conclusion, all right, I hope this was helpful, but I want you to know that psoriasis is consistently associated with poor quality of life and psychological dysfunction. And the biological mechanisms may be connected by systemic inflammation, particularly through neuroinflammatory theories of depression. I think there's much more work that needs to be done in this area, but through advocacy, multidisciplinary teams treating people with psoriasis, and simple psychological techniques and healthy lifestyle, you can feel better about living with psoriasis and get the support and the help that you need to live a high quality of life and to get over the mental health comorbidities that are plaguing so many people living with psoriasis. So with that, it looks like I left about 10 minutes for questions. I'm just gonna go through my references really quickly, and we'll take some questions.
Well, thank you, Dr. Rieder, for your presentation. It was very interesting. Now time for the Q&A portion, as Dr. Rieder mentioned. So our first question: psoriasis is said to be due to stress, which you mentioned. During these COVID times, we've experienced double stress. Can you expect a flare-up during such times?
It's a great question, and I think it depends on a lot of things. The year 2020 and it appears that the year 2021 are going to be stressful times for all of us for different reasons and to different degrees. I think it's reasonable to expect to have a flare, and I think to do something proactively about it. It's the perfect time to sort of enact things that I was talking about on those last few slides, like those psychological tips and tricks, using those deep breathing techniques, the progressive muscle relaxation to get yourself in a state where you may not be as susceptible to that chronic stress, to that chronic sort of cortisol surge that's happening to your body, to put your body in sort of this fight or flight modality. And I think you should be proactive about that, because I think that it would be reasonable to expect that people's psoriasis will flare. I haven't seen a ton of it in my practice, but I have seen a couple other stress responsive conditions happening, like wildfire, people shedding hair during coronavirus, and a couple of inflammatory diseases of the skin of the face that's associated with mask wearing and inflammation there.
And what comes first, mental health issues or psoriasis? Such a diagnosis is enough to send you over the edge.
Yeah, no, I think it's a great question too, and I think it depends on the person, sort of the chicken or the egg. If you're thinking about depression as a inflammatory, evaluate inflammatory theory, there's an external stress that may happen to the body, and psoriasis and depression may happen at the same time. But I think, like I said before, when I was talking about sort of anxiety and social anxiety, there's lots of different reasons that psoriasis may interact with depression. Depression may be something that a depressive episode can be a stressful event and we know stress can trigger psoriasis. Depression may happen as a result of psoriasis and the way that people feel about their skin and their self-image, and just the uncomfortable sensations of living with these scaly plaques, and some of them that may be unsightly. Or it could be a reaction to the responses of the observers. All right, and there's many different ways to get there, and I think it depends on the person and the situation, and it depends on their social supports. It depends on what they're doing for work. It depends on if there are other systemic conditions that people are living with. So it's a really good question. It's a really nuanced one, and it's one that I don't have a straight answer for. And that's what makes the psychological professions interesting, because everyone is very unique and everyone brings a different narrative with them.
And is there still a stigma around psoriatic plaques? Do you have any tips to help maintain confidence?
I think that there is a huge stigma among people who don't know. And unless you have a family member with psoriasis or a really good friend with psoriasis, or you are working in the healthcare professions, and even if you are, you still might not know what psoriasis is. People still think that psoriasis is an infectious disease. So the easiest way that I found to deal with it is sort of use the techniques that we tell kids to do, and that's sort of diffuse things really easily. And so if someone's talking to you about it, or if someone's looking, kids are actually a lot easier to deal with, because they'll just be like, what the hell is that? And they won't hold anything back. Adults will silently judge. But you can sort of diffuse things by saying, oh, that's just my psoriasis. You can't get it for me. It's not infectious. And then move on to the next topic like it's sort of ho-hum. And sort of just try to diffuse the situation and switch the conversation. And think about it. And if you sort of project, even if you're feeling stressed inside, it's like the analogy of like the ducks floating on the lake. They do so very, very calmly, but underneath the water, they're paddling very, very quickly. It's sort of like sitting with that feeling of stress on the inside, but projecting confidence on the outside. Much easier said than done, but very easy to diffuse that situation if you just kind of brush it off.
And what do you recommend a loved one say or do to emotionally support someone with psoriasis and psoriatic arthritis during a flare-up?
That's a really great question, and I think it depends on the personality of your loved one. And I think the most important thing you can do is listen, is to be present and to listen. I think I'll just share personally, like I'm stereotypically, I have sort of male type stereotype behaviors when it comes to when people are having a problem. I want to think about a solution for it, but often the answer is not to find a solution, is to just listen and be present and to be available. If you need to offer words of reassurance, you can do that, especially if you have someone who's been living with psoriasis for a long time and you've seen flares before, and you can sort of remind them the brain has an interesting way of having amnesia for traumatic experiences in the past, and we don't tend to view them as traumatic as they were. So people will forget how their psoriasis flare was in the past, and they'll be like, this is really bad, and I'm going through this, and I don't know if I'm going to make it. And you can sort of remind them, you can reset them, and you can reground them and say, we've been through this before, we did it together, I'm here for you, and I'm here to listen, whatever you need.
And a question that's come in tonight, comparing psoriasis to psoriatic arthritis, is the prevalence of major depressive disorder higher?
It depends on which data you look at. Remember that slide we looked at before showing that huge range of depression in people with psoriasis? You also get a range of people with psoriatic arthritis, and it's really hard to make a comparison because it depends on what scale is used. There's a whole different types of psychometrically validated scales to measure depression in a hospital setting. There's different scales for the outpatient setting, and it's very difficult to compare these things. So to synthesize all this data you would think it would be really easy to compile it all, but because the scales are different, because the numbers of patients are different, and because the way that they're administered are different, and the locations are different, and there's different circumstances in people's lives, it's actually pretty hard to do that. So the short answer is I don't know, and I think it depends on which scale you look at, but there's times when the prevalence of psoriasis and depression may be higher, and there's different scales, different studies you can look at where the prevalence of psoriatic arthritis and depression is higher.
Okay, and my last question, is there a chemical link between sleeplessness and flare-ups?
Probably, and I can't quote the data of that on the top of my head, but it has to do with cortisol dysregulation. When cortisol gets dysregulated, you're going to have dysregulation of that whole HPA axis that we were talking about on that messy cartoon slide. When you dysregulate the HPA axis, you get a major disconnect between your neuroendocrine functions, and because of that, the effects of stress are going to be much more elevated. Sleeplessness is an incredibly stressful event. It's very difficult to function in the work setting, it's very difficult to function in the home setting, and it's very difficult to keep inflammatory disorders at bay when you are sleepless or have poor sleep. It's like such an important part of our daily life, maybe the most important thing, or the second most, next to consumption of proper nutrition. But I would think that the link would be in the I don't know what the molecule itself would be, but it probably is going to be in levels of cortisol.
So I guess it really is important to have 8 hours of sleep.
Well, so yeah, I mean, I think it depends on the person, right? Everybody has a different set point, and I think that I don't know if all the listeners here are in North America, but most people in North America are told to sleep, at night, and that's really, it's a convention of sort of Western society. It doesn't make a lot of sense. Our primary drives for sleep are about 3 in the morning and 3 p.m. That's why a siesta, it makes a lot of sense. If you feel like lazy and tired in the middle of the day, regardless of how you spend your day, it's because your body has a natural drive to sleep at that moment. And that's why in an ideal world, we would all be having a siesta to rejuvenate our bodies. But in general, people need about, on the low end, 6 hours, up to 8.5 hours, but there's people on the higher or lower end of the spectrum on that, and it really depends on people's set points. But you're not supposed to get sleep in like a continuous period like we do at least in America. It doesn't make any sense, but that's unfortunately what we do. But sleep is so important to restore all sorts of bodily functions and keep us going at a smooth rate.
That's very interesting. Well, thank you, Dr. Rieder, for taking time to answer the many questions we received and for sharing your expertise about related mental health issues for people with psoriasis and psoriatic arthritis. We really appreciate your time tonight.
Thank you, Bev, and thank you for the foundation for having me, and thank you for everybody answering some really good questions.
And if you'd like to connect with someone who has psoriasis and or psoriatic arthritis, contact the Foundation's one-to-one program to speak with a trained volunteer who can offer the information and support you need. To start, simply complete the match form at psoriasis.org/1-2-1. In addition to today's webinar, podcasts are also available through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. If you'd like to listen to similar topics, such as number 38, The Emotional Side of Psoriasis and Psoriatic Arthritis, by dermatologist and psychologist Dr. Richard Fried, who Dr. Rieder mentioned earlier. Number 65, My Don't Give Up Attitude About Living with Psoriasis from volunteer Howard Chang. If you have any questions about the COVID-19 vaccines, be sure to catch episode 111 with just Dr. Joel Gelfand and Dr. Christopher Richland. Contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease if you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments. You can contact the Patient Navigation Center by phone, email, or live chat as indicated on the screen. You can also contact the Navigation Center about connecting with others through the one-to-one program, which I mentioned earlier. Reach out at education@psoriasis.org or call 800-723-9166, option 1. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. Thank you again to our sponsors, Bristol Myers Squibb, Janssen, Lilly, and Novartis for their support of today's webinar. Finally, you can access our webcast archive at psoriasis.org/watch-and-listen. This concludes our presentation for today. Thank you for attending.